Hello, and welcome to the third of a series of webinars looking at the care of hematology patients during the COVID-19 crisis. We already had two very successful webinars focusing on the general risk of COVID infection and the risk of patients suffering from hematologic malignancies, while in this webinar that is organized by EHA and the Thalassaemia International Federation, we will move our focus to non-malignant conditions like thalassemia and sickle cell disease and COVID-19. This is a live webinar, so you in the audience will be able to submit questions, and we will ask the questions to our speakers and they can share their experience and personal recommendations. And again, we will collect all your questions and they will also help EHA shaping future webinars. So please submit questions to us and we will see how we can accommodate your requests. Today, we are joined by three speakers that will help us understand the strategies to mitigate risks in thalassemias and SCD during the COVID pandemic. So let me quickly introduce them to you. We have Professor Nica Cappellini, Maria Domenica Cappellini. She is from the University of Milan Medical School in Italy. Hello.
Hi, nice to see you.
We have Dr. Raffaella Colombatti, coordinator of the Red Cell Disorders Working Group of the Italian Association of Pediatric Hematology Oncology in Padova, Italy. And we have Dr. Androula Eleftheriou, that is the executive director of the Thalassaemia International Federation in Cyprus.
Hello.
So, hello. To start, we will have Professor Cappellini to give us an introduction, an overview of thalassemia syndromes and the management of thalassemic patients during the COVID pandemic. So if we can have our slides, please. Yes.
Okay, so good afternoon to everybody. If you can move the slide, Francesco, please. What I'm going to do is to give you a short introduction on thalassemia for those of you who are not familiar with thalassemia patients. And then I'm going to pose some question for how these patients are exposed to SARS-CoV-2 infection. And finally, I will provide you some information regarding the Italian situation based on a survey. So can I have the first slide, please?
Yeah, I'm trying to advance it for you. It's a little slow, and sorry.
This is the last one. Okay.
Yeah.
Okay.
Okay.
So no. Oh, this one. Next, please. Okay. As most of you know, thalassemia syndromes are an heterogeneous group of autosomal recessive inherited disorders caused by reduced or absent hemoglobin chain synthesis, leading to ineffective erythropoiesis and subsequent chronic anemia. According to WHO, thalassemias represent one of the most frequent causes of anemia, affecting more than 7% of the world population as carrier. Next, please. So, although the high prevalence of the mutation regarding the globin chain genes are mainly centralized in South Mediterranean countries, Middle East, and Southeast Asia, recently, during the last few years, due to recent migration, thalassemia are becoming an evolving global burden, and that is going to involving countries where thalassemia was almost unknown, especially North European countries and USA. Next, please. If we consider the mutation of the globin gene responsible for thalassemia, we may list more than 400 mutations, which could be more severe or less severe. But to make the clinical approach to thalassemia easier, I think is useful to have a clinical classification which take into account the transfusion requirement. So looking at this slide and this arrow, you may see the two extreme. At one extreme on your left side, the yellow one, there are carriers. So subjects who are asymptomatic, they are characterized by very mild microcytic anemia, but they don't usually require any therapeutic support than folic acid or something similar. But on the other extreme, in your right, you can arrows where we locate the severe thalassemia patients, those who require regular blood transfusion to survive. So this group of patients are named transfusion-dependent thalassemia patients. And as I said, they require from 2 to 3 units of blood every 2 to 3 weeks in order to have a normal level of hemoglobin or approaching the normal level of hemoglobin. That's for all their life. And associated to that, they need an iron chelation to remove the iron accumulated by transfusion, which is very toxic for the organs. In this definition of transfusion-dependent thalassemia, we include the well-known beta thalassemia major, usually are the homozygotes for severe mutation. We include the severe hemoglobin E thalassemia, which are forms mainly frequent in Southeast Asia, and also the hemoglobin eye drops, fetalis. In between these two extremes, there is a wide spectrum of clinical expression or phenotypes, which are defined as non-transfusion dependent thalassemia because they are capable of maintaining an hemoglobin level between 7 and 9 by themselves. They may require occasional transfusion in some circumstances, such as pregnancy, surgery, infection, but some of them are really occasionally transfused. So with this scenario, it's important to know that these patients, according to the severity of the clinical phenotype, they develop several comorbidities. Next, please. And the comorbidities may differentiate a bit between transfusion dependent thalassemia patient and non-transfusion dependent. In transfusion dependent patients, the complication or comorbidities are mainly due to iron accumulation. And although most of the patients are receiving a good iron chelation, but nevertheless, some organs remain affected by iron load, heart, liver, endocrine. So these are mainly complication in transfusion dependent patients. In non-transfusion dependent patients, although there are some complications due to iron accumulation which accumulate to increase iron absorption because of anemia. Besides that, there are some other complications which are peculiar for anti-DT patients, especially extramedullary hematopoiesis masses, increased risk of thrombosis, so they have an hypercoagulable states, some renal involvement, and so on. So with this scenario, it's come clear to pose some question on how thalassemia patients may be affected by the corona infection, how COVID disease may have a clinical course. Next, please. So this is the question. Are patients with thalassemia more susceptible to COVID-19 disease? The answer is we don't know yet. There are no data already published, so these are some thoughts that we can discuss together. I should say that having presented the very complex clinical feature of this patient, it comes to our mind that as a patient with pre-existing chronic morbidities, thalassemia patients may be or could be more severely affected by the SARS-CoV-2 infection. But again, I said, so far, there are no significant or relevant data in the literature. Second consideration, the majority or a large proportion of thalassemia patients are splenectomized. And we know that splenectomy renders these patients vulnerable to bacterial infection, and it can trigger serious and life-threatening sepsis. What about splenectomy and risk of viral infection? Based on the past, based on what we know, is not known that viral infection or severe viral illnesses. But coronavirus is new. We don't know how it can affect these patients. So far, apparently, being splenectomized is not, in general, a risk of getting more infected or having a more severe COVID. Third consideration, these patients, or at least the severe forms, are receiving regular blood transfusion. I mentioned every 2-3 weeks. So definitely patients, but also physicians have some concern on how the virus, the coronavirus, could be transmitted by blood transfusion. So far, there are no evidence that COVID-19 may be transmitted through blood. So these are very simple thoughts, and let's see what we know so far. Next, please. So I'm quite confident today to present the Italian experience based on a survey which was conducted by the Italian Society for Thalassemia and Hemoglobinopathies. I can be a little bit more precise because the paper has been accepted yesterday on the American Journal of Hematology, so data will be available. The censor of the data is updated on April 4th because we included only patients who had at least 2 weeks follow-up. And I can say that we starting from beginning of the pandemic, immediately from beginning of March, we recorded 11 cases, and the patients were all in the northern part of Italy, where the pandemic has been the most widespread spread. And what I can comment is that all of them experience a relatively mild to moderate COVID disease. Take into account that based on on the society network, we may register the approximately 5,500 transfusion-dependent thalassemia patients all over the country, and 1,500 non-transfusion dependent patients. The number I just mentioned are relatively low. So why are relatively low than expected? Of course, maybe other cases will come around, but now that the spread of infection is fortunately slowing down, we are not expecting to have many more cases. And why that? Well, we don't have a clear explanation yet, but probably is likely due to earlier and more vigilant self-isolation. The patients were very, very careful, so they self-isolated more than the general population. All the patients, the 11 patients, had some associated comorbidities. 72 of them, so 8 out of 11 were splenectomized, but splenectomy did not affect the clinical course. And we were able to identify the potential source of infection in 64% of the cases. 3 of them had probably an occupational infection because they were nurses working in hospital. Next, please. Approximately 55% of the patients, no, approximately, actually, 6 patients were hospitalized, but no one required ICU. We had only a single patient belonging to my center who had a more severe symptom and require an intensive ventilation support with continuous positive airway pressure. But actually, this patient is a lady, 55 years old, with thalassemia major, who had last year beta cell lymphoma, treated with chemotherapy. And now, although she is in complete remission, but you can imagine she had some pre-infection background. Among the patients admitted to the hospital, only 3 required a specific treatment, or at least being admitted in a very early stage. The treatment was not yet well defined. Anyway, 3 were treated, 1 with one with hydroxychloroquine plus anakinra, and 1 with hydroxychloroquine plus 2 antiviral agent. What is interesting is that in these cases, we didn't observe any increase on blood requirement. Next, please. Next slide, please. So just to conclude, as I said, probably the fortunately low number of patients infected was due to self-isolation, but also I have to say that the Italian center immediately at the beginning of the spread of the viral infection, implemented some specific measure. All our thalassemia and sickle cell patients had been advised immediately by phone calls, email, or directly at the center to follow the containment measure, which were published immediately on the website of our association. Next slide. And what we did was to offer patients a safe track at the hospital in order to receive their life saved treated in COVID-19 free areas. So we made sure that patients could be treated properly, and the healthcare personnel was prepared and was educated to treat to apply all the measures required. To prevent access of symptomatic patients, the hospital door filter and temperature check was preceded and followed by our phone and ward access triage. And symptomatic patients were, of course, receiving their own care and transfusion in a dedicated COVID areas. So with this measure, we thought that we were able to contain also the diffusion of the infection in thalassemia patients. Is a preliminary, are preliminary data, but I'm not expecting to have a significant increase in numbers. Now, this is the Italian experience, but the Thalassemia International Federation actually started a more extensive survey for other countries in Europe. So I'm passing to Dr. Androula Eleftheriou, which is the Executive Director of Thalassemia International Federation, to present the results of their survey.
Thank you very much, Professor Capellini, and thank you for this opportunity. Well, Thalassemia International Federation has focused very early and has responded to this pandemic COVID in different ways. First and above all, by providing valuable information for our patients, for the global patient community, but also for collecting information in order to better identify the challenges and the concerns that potentially or in real life facing our patients all over the world. First of all, thank you, Professor Capellini, for putting the real scene and for putting this data together from the Italian centers, because global collaboration is absolutely essential now because of the many unknown aspects of the impact of this virus in humans generally, and more particularly in special patient groups, such as our thalassemia patients. So first slide, please. Can I have the first slide, please? Thank you. No, that was thank you. So one common challenge that our patients globally are facing, both in Europe and elsewhere, is a shortage of blood. And this has been mentioned by the greatest majority of our community advisory board members who are actually working at the local, national, regional, and international level, networking with healthcare professionals and with their peers across a country, across a region, providing as reliable as possible information to the Federation so that we can be as helpful and supportive as possible effort. So the blood shortages was a very important challenge that all the patients are facing. More than 90% are reporting from moderate to severe shortages, and particularly in large population countries where the patients, the donors have to travel, and they are very much restricted from actually donating blood, or and the patients on the other side cannot access their transfusion centers. So more than 90% are actually reporting a very large drop of their pre-transfusion hemoglobin, and only a very small part are actually reporting adequacy of blood. More than 95% are actually coming from the world, mainly in Europe, but not restricted. We are very much concerned because shortages in blood are actually diverting people and decision makers into practices that we wouldn't like to see, practices that we have avoided and we have prevented in order to secure the safety of blood supplies, such as returning to family donation practices. The majority of them are reverting to family and friends donation practices as an outcome to the shortage. A percentage of them, and I'm going to be able to give more precise percentages at a later point in time by the end of April when we codify the results of our questionnaires and our surveys, but they are also reverting to whole blood donations and older age of blood provided to these patients. The next, please. So on the one hand, the next slide, please. So on the one hand, we have this dramatic effect that shortage of blood has on a great majority of our patient population, both in Europe and elsewhere, more severe in the developing part of the world. But also this pandemic has brought us to focus on the necessity to implement and strengthen some of the programs that we have forgotten about or we have not implemented to the length that we should have. It brought about the need to strengthen vigilance programs, patient management programs, better clinical use of blood, and creation of national inventory to actually combat the needs of patients in different parts of the country. Most of the blood transfusion services, we are very happy to say that across the world have reform policies such as blood donation questionnaires, developing the post-donation questionnaire to follow up their donors' health, have reduced their transfusion units but increased the frequency of coming to the clinic. On the one hand, giving opportunity for safer management, transfusion management, but on the other hand, in places where not strict preventative measures have been taken in hospital and transfusion centers, mostly in the developing world, are bringing the patients for greater risks in visiting more often their centers. There has been a great contribution of NGOs in blood donation in most of the countries, in empowering blood donation, in collaborating with blood transfusion centers to actually safeguard that the donors are in an environment to give blood. And from the last webinar we have had 2 hours ago, it appears that probably we in the next few weeks more strengthened blood donations happening everywhere, but blood shortage is becoming more and more severe as the lockdown remains, and this is very tragic for our patients, and the distinguished speakers on this panel know, as well as those who are involved in the care of these patients, consequences of suboptimal blood transfusion. And we have heard from the webinar that patients are going to centers or to hospitals desperate of finding blood when their pre-transfusion hemoglobin, their hemoglobin falls below 5. So that that in their desperation of blood transfusion, of course, creates problems in that they receive any blood that that hospital may have to give them, with great development of a percent viral immunization and other adverse reactions, as the treating doctors have disclosed to us in a previous webinar we had from across the world. And the last slide, please, is referring to some information we have. The flow of information is tremendous. As we speak, considerable more information comes from across the world. But I would very initially and very preliminary agree with Professor Capellini that the information we get on the patients infected with SARS-CoV-2 are in their greatest majority recovering, some with hospitalization, others without hospitalization, but they are discharged and returned back. Of the 51 patients, only 3 have passed away, 15 days post hospitalization. So from the 51 patients that have been infected with the virus, across ages between 13 to 57 in the countries that are shown in the slide: Cyprus, Italy, France, Turkey, Iran, Pakistan, Indonesia. And as we speak, flow comes in for more data and information. Across all symptoms that are ranging from liver iron, severe liver iron concentration, to mild myocardial and mild liver iron, splenectomy, 8 of them, diabetes 18, pulmonary hypertension 2, severe iron concentration and past-stage severe infection, 12 of them. So we are hoping that in the next few days we'll be able to codify, based on the clinical surveys that the treating physicians are providing along with the information from the patients, so that we can be able to assess better the situation. The Federation had focused considerable attention to collect data. It's very important. No nation can do that alone. We need a global collaboration to actually assess the impact that we have, because from what we preliminarily see, there is an unanticipated clinical progression. There is no data, as Professor Cabellini said, to actually underline which of these comorbidities or which of these parameters are actually contributing to a less or more severe progression. So we hope that with the Italian data that, as always, are amongst the first countries that provide us so much useful information for our patients, we hope that we will have more information to support that data and give better guidance for our patients' safety and information.
Thanks a lot. Thanks a lot, Dr. Eleftheriou, and thanks a lot, Professor Capellini. I'm passing the ball now to Dr. Colombatti with just one request. Please try to stay within the times, because we have promised we're going to answer questions. Questions are coming in, and it would be interesting to address them, of course. So please.
Thank you for dedicating a space of this webinar to sickle cell disease. Next, please. In my presentation, I will just recall a few basic characteristics of sickle cell disease that is important to reconsider during a pandemic such as the COVID-19 pandemic. Sickle cell disease is a genetic disorder of hemoglobin, or better, they are genetic disorders of hemoglobin with hemolytic anemia, vaso-occlusion, and risk of infection, but with extreme phenotypic diversity. Sickle cell disease is a chronic disorder with organ complications since infancy, starting in the brain, the kidney, the lung, and with the need of chronic routine healthcare and treatments, whether drugs or transfusion, meaning that the patients will need to come chronically to the healthcare facilities, even in time of a pandemic. But sickle cell disease also is characterized by having acute manifestations that are unpredictable and can be severe, like sepsis, vaso-occlusive painful crisis, acute chest syndrome, or stroke. And this can happen at any time. The next, please. So, what is specifically known about sickle cell disease and COVID-19? Well, there are 4 published cases of acute chest syndrome due to COVID-19 in France, the Netherlands, and the United States, and all were published in the past month in the American Journal of Hematology. And I'm not going to go into detail of the treatments, but or the diagnostic paths, but what is important to consider from these first preliminary 4 cases is that vaso-occlusive crisis can be a trigger of acute chest syndrome, and also the infection can be a trigger of vaso-occlusive crisis and then of acute chest syndrome. We must remind that half of the acute chest syndrome that happen in sickle cell disease patients occur after a vaso-occlusive crisis. COVID-19 acute chest syndrome happens while in adults. So while infectious causes are less common in adults and more frequent in children, in this case, we have an infection that can cause an acute chest syndrome. What are the criteria for COVID-19 infection in screening, diagnosis, and resolution? They're not the same everywhere in the sickle cell patient, but this is because they're not the same in every country and even in regions or states in countries. And this is important to consider. And then what is the treatment that is needed for COVID-19 infection in sickle cell disease patients? Can it be similar to the approaches for the general population? Or even in this case, they are different in different parts of a single country or in different countries? And these are all questions that we still have on the floor. And then what we know, and has been discussed in the past 2 months in the sickle cell community, is unpublished information that comes from expert discussion or expert opinion sharing across continents through scientific society. The next ones. So are patients with sickle cell disease more susceptible to serious COVID-19 disease? Well, we have to consider 3 things. And the first one is sickle cell disease pathophysiology. Can you press the button, please, for the next slide? Okay, so 4 things. Sickle cell disease has vaso-occlusion and ischemia reperfusion injury. It has increased inflammation with activation and inflammatory responses. It has endothelial dysfunction, and it has activation of coagulations. All these things need to be kept in mind because may give patients with sickle cell disease a higher risk of developing complications during COVID-19 infection. Next slide, please. Next one. Yes, thank you. Then there are a few key elements. Nika already talked about asplenia in thalassaemia patients. Sickle cell disease patients have functional asplenia. Some are also splenectomized due to splenic sequestration. And of course, they have increased risk of severe bacterial infections. Sickle cell disease patients have acute events like vaso-occlusive crisis and fever with access to healthcare facilities. And we must remember, as I said, the acute chest syndrome is the second most frequent clinical complication and reason for admission in sickle cell disease, even outside the COVID-19 pandemic. Next slide, please. So what about COVID-19? Well, this is a sentence from one of the recently published papers. It's not only a lung infection, but more and more evidence considers it as a progressive endothelial inflammatory syndrome involving the macrovascular bed of the lungs, the brain, and other vital organs. So it's not only a lung disorder with bilateral pneumonia, but it also brings a systemic inflammatory response that's been defined as a cytokine release syndrome, even in COVID-19 infection, with increase in IL-6 and IL-1, diffuse thromboembolism and coagulation activation, and there is increasing evidence of other organ involvement like the brain, the kidney, the spleen, the digestive tract, and in children, there are many reports of vasculopathy of the extremities, even if we know that children do not have severe manifestation generally as the adult population has. So you can see that all these characteristics of COVID-19 over a pathophysiology as sickle cell disease can be really worrisome. The next one. So what has been done so far in these first few months of the pandemic? The sickle cell community globally has responded with many efforts. The first one was to be sure to give a message that the patients needs to be protected and protect themselves, and produce educational material to stimulate the application of measures to limit exposures. I am just presenting here some of the few focused on sickle cell disease patients, like the one produced by the Sickle Cell Disease Association of America, both for providers of sickle cell disease patients and for caregivers. And thanks to the German Society of Pediatric Hematology Oncology, and you can find the website listed here, the documents were translated in Arabic, French, Spanish, and German, and are available. And another website in which you can find the material is the AeroBloodNet website that keeps track of all the published materials from European scientific society and global scientific societies in different languages. Next one, please. Of course, besides protecting patients, and we also have to consider that what is recommended by different countries is not the same. Some areas made compulsory the use of face masks and gloves, like where I live or where Nika lives now, but other areas do not recommend the same measures. So, of course, we have to consider what's going on at a national or regional or state level. But then many centers reorganize their pediatric and adult sickle cell disease services. And these are some of the measures that have been applied in our Italian pediatric hematology network or in other centers across Europe or in other networks in the UK, like the enhanced use of telemedicine and teleconsultation, reduced access for on-site visits, and in some cases, like the UK or in Paris, a safe transportation was provided and is provided for patients. The delay of non-urgent transfusion, if necessary by deemed as necessary by the healthcare staff, and this was not the case for stroke prevention in children. Dedicated pathways of access in the unit with clinical screening before entrance or distancing in waiting rooms. Coordination with local ERs and COVID teams that in sickle cell disease is necessary to plan what happens in case of acute emergencies that are common in sickle cell disease patients in order to establish adequate pathways and focus on continuation of drug supplies. Many centers have developed home delivery or alternate access for drug procurement. Next one. What about patients management? What do we know on sickle cell disease patients that have COVID? And I present this data from Professor Paolo Bartolucci in Paris. It was an example of an adult network in times of COVID pandemics in Europe. They developed a hotline telephone telemedicine monitoring system, both for vaso-occlusive crisis and for patients with suspect COVID-19 or confirmed COVID-19, receiving 500 calls in the past month. They developed home care network with 3 nurses, 3 times a day. and also with a network of health providers, and there were 70 visits in the past months, and 2 different visit circuits for a vaso-occlusive crisis of or COVID-positive patients with dedicated room, and patients are brought by taxis and ambulance with trained staff that was trained by the hematology group, and systematic screening for patients detected by the hotline, plus early treatment of suspects within 7 days of the contact. In this way, they treated 32 symptomatic screened patients, and 17 of them continued treatment for 10 days after the PCR test for COVID-19 turned back. 22 were hospitalized, 11 required intensive care unit, and 1 died. Can you, next please? And the fourth thing that was done is data collections in order to understand disease characteristics, to optimize patient management in the acute setting and in long-term follow-up. One of the examples, there is an American registry, and one of the examples of the data collection in Europe is the EuroBloodNet registry on patients with rare blood cell defects, so not only sickle cell but anemias, and COVID-19, which is a longitudinal data collection system. And the Excel sheet has already been disseminated across the network and interested center in order to collect the data in a uniform way. So the response has been fast. There is still a lot to know and to discover, and a lot of ground for discussion. What I must say is that for now, pediatric cases has been really few in our pediatric network in Italy, in spite of the pandemic coming out in February. We did not have any case, and even the reported cases from the US and the other countries are very, very few and mild. Thank you.
Oh,
we can't hear you, Francesco.
Now we can't hear you.
Unmute your...
Unmute.
Oh, sorry. Sorry. Thanks, Dr. Colombatti. I think we can jump now to the questions. We are receiving questions from the audience. I think in the audience we have quite a number of patients because they're also reporting it. You have been talking about pediatric patients. I have a question for Professor Capellini. Do we have data on pediatric thalassemia patients? And you can, of course...
So far, there are no cases in children or adolescents. The average age, the mean age of this patient I mentioned was 44 years. And the impression is that those affected are the elderly patient, let's say, on the 4th, 5th decade.
Okay, and then this links to a question that was pointing at the data presented by Dr. Eleftheriou. Do we have data on the ages of the 3 thalassemia patients that passed away, or yes, the ones that were hospitalized?
One of them was 13 years. I was just going to add to the question. There were patients aged between 13 to 19. One of the 3 patients was 13 years old that passed away.
Okay, you mean 1, 3, 13?
13, 1, 3. 1, 3, 13.
So it was actually a pediatric patient could be considered.
Adolescent.
Adolescent.
Obviously, yeah. I feel that the pediatric or cases are going to need to have more data from the developing part of the world where we have a bigger pediatric population in thalassemia, if you agree, Professor Cavalli. In Europe, due to the effective prevention, although we do have pediatric, the great numbers are in the developing part of the world, and data are probably going to come.
Yeah. is not only that, Andrula, which is definitely true, but also those patients, unfortunately, still are undertreated. So they are poorly chelated, poorly transfused. So the clinical presentation of the patients is more complex. For sure, we have to take into account that.
For sure.
Thanks. So I think this would be a question more for Dr. Colombatti. Is there a possibility that the cell abnormality reduces the risk of COVID infection? This has been probably not shown anywhere, but I don't know. Maybe you have an
I
answer
don't think
to this.
there are data so far. It's true there are very few patients with sickle cell disease and COVID-19 so far. And as Nika said, for thalassemia, it's surprising that so very few have shown up, at least in Europe. But data from the United States so far seems similar. Nevertheless, it's still too early. What we think now is that the patients were very scared to move and so did not probably get infected so much. We are also seeing that patients with sickle cell do not come to the emergency room as they used before. And so this is another thing to consider. But to answer your question, there's no information yet available.
Thank you.
And moreover, there are no data on the virus attack of red cells.
Yes.
So this is something that is not yet clear.
So, Professor Cappellini, one of the questions we received is, since you have talked about using chloroquine as a therapy, they ask, the audience is asking if you test for G6PD before administering chloroquine.
Well, that is an important question. In our patients, we already know if they have or not G6PD because they have been tested, but at least it's a question to ask the patient before starting the treatment, and based on their origin or so on, it can be useful to test G6PD. Why that? Because it's known that at least for the Mediterranean variant of G6PD, hydrochloroquine can be an hemolytic agent, which is not really true, or is less relevant for the G6PD-A variant, which is more common in Africa. So is something to consider, but of course cannot be screened for any patient to be treated with hydrochloroquine. Most of them knows, or you have to base on the origin of the patients.
Yeah, I see Dr. Eleftheriou nodding. Probably TIF has considered suggesting for at least check the status with the patient, if the patient knows of a G6PD
of course,
condition.
It's a question to ask. Yeah.
Absolutely, it's a question to ask. I fully agree. Also, most of the patients in European countries that are on registry, they're well checked. But the question needs to be asked, and this is something that we have already included in our information as a prerequisite in the cases that the treating doctor considers the use of chloroquine.
Yeah, thanks. So another very interesting question is like balancing the risks. Are there risks going into hospital for transfusion, and which risk is worse, going to a hospital or delaying transfusions? What is the point of view of TIF, and maybe you can answer
yes.
together.
I think that anyone can have a real position on this, because it does depend on the environment, it does depend on the country, it does depend on the hospital, the measures, and the spread of the infection in the particular hospital that the patient is visiting. In most of the European countries, again, that have taken very strict measures, and the centers have and the treating clinics or centers have taken particular measures for the entry and accessibility of the patient clinic. There is no probably risk than not taking the transfusion, but I'm particularly talking about the greater risk in most of the developing countries, in large populations where the hospitals have been affected by the virus. And of course, the dilemma there is whether the patient will benefit more from the transfusion at a certain level of hemoglobin, rather than staying at home until it's very urgent to get a transfusion, because in most of the cases they do not site visits, as the previous speaker has very well described, or site visits or blood transfusions at home, as in the UK and others. So in the greatest majority of the countries, they need to balance where to go, and this is a great worry. Because we feel that a lot of our patients are going to return to very low pre-transfusion, with all the tragic consequences of the suboptimal transfusion.
If I can add, for sickle cell disease, you also have to consider the indication for transfusions. Some are mandatory, like stroke prevention; those cannot be delayed. But other indication might be considered a delay according to the environment, as Andrula said, and also transportation. If the hospital can be safe due to the measures, transportation and public transportation is not always safe, and that has to be ensured for some patients.
Yeah, just to conclude that, of course, our goal is to give to our patients the best treatment as possible. So the main objective is to guarantee a safe treatment, maintaining their schedule for thalassemia. But as Dr. Eleftheriou say, there are countries where this is possible, and I can say that in Italy and other part of Europe is possible, but definitely is not the case in other developing countries, where even outside of COVID, the situation is difficult. So for those situations, we are what we have to do is to support, whenever possible, physicians to identify a green line or a safe track for maintaining at least a acceptable level of hemoglobin in these patients.
Yes.
Great. So I'm trying to put together two questions that can be answered both by Professor Capellini and Dr. Colombatti, which point out to the fact that since there is an increased risk of thrombosis in COVID-19, if you would consider giving a prophylaxis against thrombosis to SCD patients or thalassemic patients. So we can start from SCD, Dr. Colombatti.
So again, you're talking, I imagine, of sickle cell disease patients who have the COVID-19.
Yes.
So I would talk with the infectious disease people and we'll discuss it. I know that in our region now, enoxaparin prophylaxis is given to COVID-19 patients without sickle cell disease as prophylaxis. And the dose is adjusted according to the D-dimer blood test. So lower dose, lower D-dimer, higher dose, higher D-dimer. So if it's used for non-sickle cell disease patient and patients with not genetic disease, I don't see why it shouldn't be used for sickle cell disease patients. But again, I would discuss it with the expert.
I agree. We in most of Italian hospital there are trial ongoing in non-thalassemia or non-sickle cell patients with anticoagulant treatment. So I have the same comment than Raffaella. I will discuss case by case, but at least if they have pneumonia, is done. So you have to do it. For milder cases, it depends if a patient has already some risk factors for thrombosis. So it depends case by case, but definitely has to be considered.
Perfect. So we have reached 6 p.m. We can go a little bit over this time, so no worries. I would like to now ask Dr. Eleftheriou to give us a closing lecture on the initiatives of the Thalassemia International Federation and the patient pathway that has been proposed. So if we can have the slide.
Okay. Okay. The first slide, please.
No.
I think
there we are.
The first one, the next one. Okay. I think Professor Coppolini covered the global overview and the epidemiology. All I want to stress in this slide is that the biggest percentage of our patients with hemoglobin disorders are actually living in developing world, where there is suboptimal control of the disease and therefore increased risk of complications. And that is where we worry. And the slide on the right shows the very small percentage of patients globally that are actually receiving appropriate treatment as described in international guidelines and standards of care. Therefore, we have a huge population that are potentially at risk of this virus. The next one, please. The TIF has responded in two main ways to this COVID virus, to this COVID and to this viral infection. The one is to prepare material with useful and valuable information for the patient community so that they don't start searching around and have reliable and continually updated information on all the aspects of the pandemic, on what is happening globally in their country, what are the potential challenges in hemoglobin disorders, a useful guide on nutrition, a hemoglobinopathy patient pathway, as we shall see at the end, on how we propose and recommend for the safety of patients in accessing their clinical or hospital departments for transfusion and other care. We have collected common questions from the patient community, and we've developed a question and answer patient guide so that this is also continually being added new questions in order to provide as much information to the patients as possible. And the last two booklets that we have developed, one is on the blood, because obviously on the one hand we are interested on the blood supply, the adequacy of blood, enough blood supplies, but on the other hand we are always on cautiousness and monitoring the infectiousness. It is so there are so many unknown aspects, and although to date and until today the infectiousness of the virus and its transmissibility through blood has not been documented, and this has been the case with SARS and MERS as well, the other coronavirus that we have had experience before. But we have developed an information guide with everything that, with all the data that is published and available for our patients to know, and we are adding new information as we go along. The next slide, please. We are very pleased and proud to say, because the staff of TIF and the board of directors of TIF have really focused attention and have given response to 268 treating physicians with this information in 154 thalassemia clinics. The material has been translated in more than 6 languages, has been continually uploaded on the site. We've developed a series of webinars with the patients across the different cities of the world, and the material has moved to more than 50,000 recipients across these 6 regions. Therefore, I think that this is one of the greatest productive responses of TIF to provide information. The other response, of course, that I have mentioned in my previous slides was to collect information and data on the clinical impact of this virus in our retinopathy patients, something that we are collaborating with our expert medical advisors all over the world. And last but not least, we have provided early enough, and before this material was actually developed, the last material was on the vaccinations and on the therapeutic drugs, because there is a plethora of research that has focused on producing very fast, as we all know, and therapeutic drugs, which will be our solution to the problem, at least in the developing part of the world, where we cannot actually put a lot of efforts in other aspects of their healthcare systems or infrastructure. But the development of vaccines and therapeutic drugs are obviously going to be the solution. So the last, the next slide, please. The first, one of our first responses to this pandemic was for providing information and suggestions, of course, to our clinic, the reference centers, patient community, collaborating doctors, on how we felt, with the support, of course, of our advisory board, on providing safer access of our patients to their clinics. And this is a very complicated pathway with 5 different pathways along, including a 2-step triage that is on the side of the telephone, and then at the side of the daycare center, a triage within the daycare center, adding hemoglobin to the first triage, and ensuring there is a different entry and exit of the patients that come with symptoms or have to be transfused while being suspected. So this is a pathway that the treating physicians, as we shall see in the next slide, have considered in many countries, have written to us that they have adopted, customized on these pathways. We felt very necessary. As Professor Capellini has also added, it's not possible for many treating centers to actually develop this, but we feel as Thalassemia International Federation that even 10%, 60%, 70%, or 90% of these suggestions are possible to be applied in any center within or outside Europe. For us, it will be towards the benefit of our patients. The next slide, please. We have also developed a pathway for the patients that must reach the daycare center or the clinic, that are not for their transfusion, but for other care that they need to take, consultation or medical examination, that's a simpler pathway. But then again, it involves conversation with the doctor, careful monitoring, virtual consultations, the inclusion of the two-step triage, and of course, always the existence of an isolation room and the testing. We feel, the next one, please. We feel that, of course, this is available on our website. It's available electronically. What the impact we had from our members was that, as I said, they had tried to adopt or customize this proposed patient pathways with the support of their national advisory board and aligned with the national guidelines. Outside Europe, it is very difficult, but as I said before, they are picking parts of the pathway that they're trying to customize to their own infrastructure. What I would like to end up is that our patients globally are facing very, very tragic challenges, both blood supplies, shortage of blood. We are happy to see that the safety of blood is not jeopardized on account of the, until today, absence of evidence of transmissibility through blood, and hopefully this will be the case. But also there is tragic consequences on the postponement or even complete absence, deprivation of any multidisciplinary care, the greatest majority of our population. So the last slide, please, is that we feel that although there is no data to support the vulnerability of these patients to this virus, that they're more vulnerable than patients without hemoglobin disorders, we feel that there is so many comorbidities in so many patients across the world that we need to collect data. And most of all, I need to express the wish of the board and the global thalassemia community to strengthen the global collaboration and coordination. There is an absence of global coordination and collaboration, and this pandemic cannot be addressed unless there is a global effort. Thank you very much for the opportunity.
Thank you, Dr. Eleftheriou. We have to wrap up this very interesting webinar. Once more, we see a lot of good questions from the audience, a lot of good topics and experiences brought in by the experts that we're inviting. And this time we're also very grateful to the Thalassaemia International Federation to be here and to launch this call to the international community to collaborate, which is one of the most important things at the moment, for sure. All the questions that we have collected, we unfortunately were not able to address them, but we strongly invite you to join the EHA hub, both our experts here, but also the audience, of course. The EHA hub is linked on the EHA website on the main page, and it's a space that EHA wanted to dedicate to professionals in hematology who are facing the COVID pandemic and want to share experiences, want to get in touch with each other, get suggestions, ask questions, and get answers from experts and their peers. So please join us on the EHA Hub to continue discussion. And with this, I would like to thank you very much again. Thanks to our speakers, thanks to the Thalassaemia International Federation, and thanks to the audience. And see you soon in following webinars, still here at EHA.